Hello, everybody. My name is Mohamad Mohty. I'm a professor of hematology at Sorbonne University and Saint-Antoine Hospital in Paris, in France. It's my great pleasure today to deliver this lecture, which is about updating the anti-CD38 monoclonal antibodies in multiple myeloma, a summary from the latest ASCO and EHA 2019 meeting. This is part of the webinar series delivered by the International Academy for Clinical Hematology. These are my disclosures. On this slide, you can see the usual natural history of multiple myeloma these days. And actually, this disease is becoming a chronic disease thanks to the advent of many drugs, and patients are more and more using many lines of therapy, and putting all of these lines together, the patient are able to enjoy longer survival. One major family of drugs which has been a true breakthrough in the field of myeloma are the proteasome inhibitors. The first-in-line, first generation was bortezomib, but now we have second-generation proteasome inhibitors like carfilzomib and ixazomib. The second family of drugs are the so-called IMiDs, and we have thalidomide, lenalidomide, and pomalidomide. These drugs have anti-myeloma activity. They also can act on the microenvironment, but also they have an immunomodulatory activity. But now we are seeing the first results of the new generation of IMiDs, namely iberdomide, where we have seen the latest results being published during these EHA and ASCO meeting 2019. The third major family of drugs coming into myeloma are the monoclonal antibodies. And the development of monoclonal antibodies in multiple myeloma has been quite hectic, and many antibodies have actually failed in clinical trials, either for lack of efficacy or because of toxicity. 5 or 6 years ago, we had the first successful results with the anti-CD38 monoclonal antibodies, which represent now the third major family to be used in multiple myeloma. The development of CD38 monoclonal antibodies has been ongoing now in multiple myeloma for more than 10 years. Since the first patient treated with Daratumumab in 2008, we can see today that Daratumumab is already approved in the relapse setting, but also in the frontline setting. So the monoclonal antibodies targeting CD38, which is highly expressed on plasma cells, are highly effective. Because CD38 functions as a receptor, but also as an ectoenzyme on the myeloma cells. There are several proposed modes or mechanism of action. The traditional ADCC, CDC, ADCP, inhibition of CD38 ectoenzyme activity, direct apoptosis, but also, and this is very interesting, immune modulation, especially eradication of the inhibitory, regulatory, or suppressive cells, allowing to create an immunostimulatory environment which is favorable towards getting rid of the abnormal plasma cells. Today, we have 3 monoclonal antibodies directed against CD38. The chimeric antibody isatuximab, and we'll show the latest results related to this newcomer. And we have the fully human antibodies, Daratumumab, already approved, and the MOR202, which is still under clinical trials. I'll start first with Daratumumab. On this slide, you can see a summary of the current or ongoing phase 3 trials, the Pollux and Castor trial, which allowed the approval of the drug, but there are also trials combining Daratumumab with pomalidomide and carfilzomib in the relapse setting. When it comes to the newly diagnosed multiple myeloma in the non-transplant setting, we have the DARA VMP, Daratumumab, bortezomib, melphalan, prednisone, the Alcyone trial, which allowed the approval of the drug in the elderly non-transplant eligible patient. And more recently, and this was published in the New England Journal of Medicine, we've seen the combination of Daratumumab plus lenalidomide and dexamethasone, as it has been tested in the so-called MAIA trial, and hopefully this combination will be soon approved. Other combinations are being tested in the non-transplant eligible patient, especially DARA VRD. In the transplant eligible population, we do have several trials, and I'll present today, because this has been a major feature of the ASCO and EHA 2019 meeting, the first results of the Cassiiopeia trial testing Daratumumab VTD compared to VTD in transplant eligible patients. Just a quick summary about Daratumumab in the relapse setting. We know that this agent has single agent activity in relapse refractory myeloma, and that has led to the first approval of the trial. Patients who are heavily pretreated and refractory to IMiDs and proteasome inhibitors are able to enjoy up to 15 months of PFS with Daratumumab monotherapy. Of course, the ideal use of Daratumumab in the relapse setting would be the combination either with lenalidomide and dexamethasone. This is the Pollux trial published in October 2016 in the New England Journal of Medicine. And we've seen recently the updated results of this trial. You can see the updated PFS is 44.5 months versus 17.5 months for the lenalidomide dexamethasone alone. And this combination is highly effective and likely to be the optimal option in the first relapse setting. The other combination with Daratumumab is Daratumumab, bortezomib, and dexamethasone, also published in the New England Journal of Medicine. And here you can see the updated results in patients who received one prior line of therapy, showing a clear advantage for the Daratumumab, bortezomib, dexamethasone combination. One major important finding from both these trials, Pollux and Castor, is related to those patients who are able to achieve MRD negativity, and the threshold here is 10-5. And you can see these patients are going to enjoy a clearly better progression-free survival, further highlighting the value of MRD negativity in multiple myeloma, including in the relapse setting. Now moving into the frontline, and what we have seen during the last ASCO and EHA 2019 meetings is the release of the first results of the phase 3 randomized trial of Daratumumab, bortezomib, thalidomide, dexamethasone, DVTD, compared to VTD in transplant-eligible newly diagnosed multiple myeloma. And this is the so-called Cassiiopeia trial, which was performed by the IFM and Hoven cooperative groups. On this slide, you can see the summary of the design of this trial. These are transplant-eligible patients who would receive 4 cycles of inductions, either the traditional classical VTD or Daratumumab plus VTD. Then they will proceed to transplant, will receive further 2 cycles of consolidation, and then they will be randomized into maintenance. You can see here the characteristics of the populations. They are obviously balanced because this is a randomized trial taking into account the major differences. 543 patients in the Dara VTD arm and 542 in the control VTD arm. 15% of these patients were high-risk cytogenetics as expected. The primary endpoint of the trial was the achievement of stringent CR, and this primary endpoint was achieved in favor of Daratumumab VTD, where you can observe a 29% frequency of stringent CR versus 20%, giving you an odds ratio of 1.6. And if you add the percentage of patients achieving complete remission, again, you have a significant advantage in favor of Dara VTD, 39% versus 26%. Clearly, the addition of Daratumumab to the classical VTD improved the depth of response. And when you look into the different pre-specified subgroups, actually, we do have the superiority of Dara VTD across all subgroups, maybe except in the high-risk cytogenetic profile in ISS3. Another important key finding from this trial is about the MRD negativity, and this is significantly superior in the experimental Dara VTD arm, 64% versus 44% in the VTD arm, and in all pre-specified subgroups, this is in favor of the experimental Dara VTD arm. All of this together will translate towards superiority for Dara VTD in terms of PFS at 18 months, and with a median follow-up of 18.8 months. You have 93% versus 85%, and this is already statistically significant with a 0.47 hazard ratio. Again, when you look into the PFS in pre-specified subgroups, all results are in favor of a DARA VTD induction. In terms of toxicity, there is no specific new signal. We do see the usual toxicities of VTD and the usual toxicities of Daratumumab. Of course, peripheral neuropathy is around the corner. We do see some more neutropenia when adding Daratumumab, but this does not translate towards clinical complications. When it comes to adverse event of interest, again, there is no specific signal except maybe for lower yield of stem cell mobilization when using Daratumumab in combination with VTD. And of course, there are some pathophysiological explanation to this. So in conclusion, this Cassiiopeia trial has clearly established the combination of Daratumumab and VTD as a strong and valid treatment option for induction in newly diagnosed multiple myeloma who are eligible to transplantation. And hopefully this combination will be approved soon. The other highlight of anti-CD38 monoclonal antibodies from ASCO and EHA 2019 was about the results, the first results from an isatuximab-based randomized phase 3 trial. On this slide, I tried to summarize most or the major phase 3 trials which are currently being conducted using isatuximab. And for the first time, we had the release of the data of the so-called Icaria trial in relapsed and refractory multiple myeloma. This was presented by Dr. Richardson. This is a phase 3 randomized open-label multi-center study comparing the combination of isatuximab, pomalidomide, and low-dose dexamethasone versus the classical relapse treatment, pomalidomide and low-dose dexamethasone. This is the design of the trial. These were patients who received at least 2 prior lines of therapy, including lenalidomide and a proteasome inhibitor. Of course, they didn't receive any prior therapy with pomalidomide. This was a 1-to-1 randomization, either the usual pomalidomide dexamethasone, as it has been approved several years ago, or isatuximab plus pomalidomide dexamethasone. The primary endpoint was progression-free survival as independently evaluated by an independent committee. You can see the characteristics of the patient. 307 patients were included, median age 67, and 20% of these patients were above age 75. You can see the different distribution, and up to 19.5% were in high-risk cytogenetics. Of note, the median time since initial diagnosis was 4.2 years, with limits going up to 20 years. This is a relapse trial, so it's very important to have a clear picture about the prior anti-myeloma therapies and the refractory status. These data are summarized on this slide. You can see, as per inclusion criteria, 100% received a proteasome inhibitor and an IMiD. 90 to 96% received the prior alkylating agent. and around 55% received the prior auto transplant. 95% were IMiD refractory, 93% len refractory in the IPD arm, 75% proteasome inhibitor refractory, and 73% were IMiD and PI refractory. Up to 98% were refractory to the last line, and 60% were refractory to lenalidomide as last line. The trial was able to achieve its primary endpoint with a median PFS at 12 months of 11.5 months versus 6.5 months for the control arm, and this gives you a hazard ratio of 0.59 in favor of adding isatuximab to pomalidomide dexamethasone. Looking into the different subgroup analysis, all the results are positive and consistent with an advantage in favor of the isatuximab pomalidomide dexamethasone. Looking into the response summary as assessed by the IRC, you can see that there is an advantage in favor of the experimental arm, isatuximab pomalidomide dexamethasone, 60% ORR versus 35%, and it's important to highlight that the response was rather quick, 35 days median time to the first response. Another important message, you have around 15% of near CR in the experimental arm compared to 3.3% in the control arm. A few number of patients, 5%, were able to achieve MRD negativity with the isatuximab pomalidomide dexamethasone combination. Here you can see the overall survival data already showing some advantage in favor of isatuximab pomalidomide dexamethasone. When it comes to side effects, there is no specific warning or negative signal, and the addition of isatuximab to pomalidomide dexamethasone did not induce an increased mortality or increased side effects leading to discontinuation. You can see the summary of the different toxicities observed in this trial, and this is really consistent with the safety profile we already know about pomalidomide dexamethasone and the use of an anti-CD38 monoclonal antibody. Like it is the case for Daratumumab, the vast majority of the infusion-related reactions are observed during the first infusion. Of course, one would expect that adding an IV drug like a monoclonal antibody, isatuximab, to an oral combination may impact the quality of life of the patient because of the need to come frequently to the hospital. Actually, that was not the case because the global health scale over time comparing the two groups was similar and was maintained. So in summary, this trial, this is a summary of the authors of the presentation from ASCO and EHA 2019, is that this randomized Icaria trial is establishing a new combination with pomalidomide dexamethasone and isatuximab in the relapsed refractory myeloma patient, and it's very important to note that this is this combination is clearly of great value, especially in those patients who are refractory to lenalidomide. And we know very well that lenalidomide is frequently used for maintenance after transplant, and many patients may become resistant or refractory to lenalidomide. So isatuximab, pomalidomide, dexamethasone is an important option with a good safety profile. I highlighted the issue of IV infusion when it comes to anti-CD38 monoclonal antibodies, and this is something of concern to the patient, but also to the health system. And we have seen during the last EHA and ASCO 2019 meetings, the first presentation of the results of the randomized open-label non-inferiority trial comparing IV daratumumab to subcut daratumumab. This is the Colomba trial presented by Dr. Mateos. You can see here the design of this trial. This is a non-inferiority trial. These are patients with relapsed refractory multiple myeloma. They should have received at least 3 prior lines of therapy, including a proteasome inhibitor and an IMiD, or they should be refractory to both a proteasome inhibitor and an IMiD. And it's a 1-to-1 randomization. The treatment is quite straightforward, either the classical Dara IV or Dara subcut using a fixed dose of 1800 milligrams. And I'd like to emphasize here that this fixed dose has been validated in a previous phase 1-2 trial, a so-called PAVO trial, which established the safety and pharmacokinetics of this fixed dosage of daratumumab. There were 2 co-primary endpoints, the response rate, but also the maximum concentration. In other words, the aim of the trial was to determine the efficacy, PK, and safety of this new subcut formulation of daratumumab. You can see the distribution of the patient, more than 500 patients. Of note, the median weight was around 73 kilograms in Dara IV and 72.4 in Dara subcut. You can see the ECOG status, the ISS stage, all of these characteristics were comparable between the 2 groups. When it comes to high-risk cytogenetics, there were slightly more high-risk cytogenetics in the subcut subgroup. Patient disposition, you can see that the percentage of patients who discontinued the study treatment was similar. We do have a relatively short follow-up, but this is quite usual for a heavily pretreated population. And when it comes to progressive disease, the patient disposition is also similar between the 2 groups. On this slide, you can see the infusion duration and treatment exposure, and you can appreciate that at any given time, you needed 5 minutes for the subcut injection, daratumumab subcut, versus 7 hours for the first infusion of daratumumab, more than 4 hours for the second infusion, and more than 3 hours for the subsequent infusion. So clearly, as expected, the daratumumab subcut formulation reduced the administration time. And this, of course, can be only highly appreciated by patients. When it comes to the primary endpoint, definitely the trial could establish the non-inferiority of the subcut formulation, 41% versus 37%, and the response rate, especially when it comes to more than VGPR or more than CR, are strictly comparable between the 2 groups. When it comes to the maximum concentration, which was the other primary endpoint, clearly this endpoint was achieved, and the trial met its non-inferiority criterion when it comes to this. When you look to the subgroup analysis of overall response rate, all subgroups will benefit from the subcute. And if you focus on the weight of the patient, whether small weight less than 65 kilograms or a heavy weight more than 85 or in between, all of these subgroups are going to benefit from DARA subcute. In another word, the fixed dose of DARA subcute is valid irrespective of the weight of the patient. The secondary endpoints, among them you have PFS and OS, and they were comparable between the treatment groups. We know about the infusion-related reactions. With Daratumumab IV, you observe 34.5%, and interestingly, the incidence of infusion-related reaction was significantly reduced with the subcute formulation. And another important message is that these infusion-related reactions were mainly of grade 1 and 2. You can see here a summary of the most common any grade or any severe grade 3 to 4 side effect. And to make a long story short, one could conclude that the safety profile was comparable between DARA subcute and Daratumumab IV. If you look to the modified cancer treatment satisfaction questionnaire, as expected, patients were more satisfied when using the subcute form, and this is quite well expected. So in conclusion, this non-inferiority trial has established the efficacy and safety and feasibility of the subcute formulation of Daratumumab, and this is great news for the patient, but also to the overcrowded hospital beds and unit. The safety profile is comparable. A flat dose of 1800 milligram is the optimal dosage, and hopefully in the near future, patient will have access to this subcute formulation. So as a general conclusion, when it comes to this topic of anti-CD38 antibodies, what we can say from the major trials presented during ASCO and EHA 2019 is that the anti-CD38 antibodies, whether Daratumumab or Isatuximab, are becoming key players in the myeloma landscape. It's not anymore only about the relapse setting, but also the frontline setting. Combination with these antibodies are allowing to induce deeper responses, including high rate of MRD negativity, as we have seen in the Pollux, Castor, but also Cassiiopeia trial. Until now, there is no significant or unexpected safety signals. As a matter of fact, we still need to work on criteria in order to select the optimal option, but also the optimal sequence of therapy and when to incorporate these antibodies and with which partner. Obviously, efficacy is a key factor. Safety is another important key factor, especially those patients with comorbidities and frailty. We do have to figure out cost effectiveness, but also, of course, quality of life. I think at the end of the day, whether we are tackling the frontline setting, in other words, treating patient at diagnosis, or whether we are tackling the relapse setting, we would like to achieve the deepest possible response. This is why more and more we insist on MRD negativity, but also evaluation of the disease by imaging, especially negativity of PET scan, because actually the deepest response is going to correlate with an improved outcome and survival. So the choice of the right sequence is of great importance, and one should not hesitate to switch class, but I think also to switch into novel combinations as soon as the first relapse. And I believe that monoclonal antibodies directed against CD38 should be a part of the standard care of treatment, standard treatment of care for all myeloma patients at time of relapse. With this, I'd like to thank you all for your attention, and I'm more than happy to take your questions